I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. Hi, I'm Tamara Thomas, and welcome to Urban Health Weekly, where we talk about medical news and health topics that matter to you. I'm here with Lou today. How are you?
Hey, how you doing? All good.
We're just going to jump right in. So I want to talk about, we're going to talk about value-based care versus fee-for-service, which is the future of medicine. But first, increased public assistance tied to better cancer survival with Black patients. Overall survival in Black patients with cancer improved significantly, and racial disparities in cancer survival decreased, with increased state-level spending on public welfare programs, a large retrospective review showed. Every 10% increase in public welfare spending was associated with an 8.6% improvement in cancer survival among Black patients, almost 4 times greater than the overall increase in survival when looking at all patients with cancer. At the same time, the longstanding Black-white disparity in cancer survival declined by more than 40% with the additional spending, reported Justin Barnes, MD of Washington University in St. Louis. The study added to existing evidence that investment in public welfare can mitigate structural racism and at least partially address social determinants of health, such as financial stability, education, place of residence, and insurance status, said ASCO Chief Medical Officer Julie Grallo, MD. Overall, the results showed that with every 10% increase in public welfare spending, 5-year overall survival improved by 2% for all patients with all cancers, including a 2.6% improvement for white patients with cancer and an 8.6% improvement for Black patients. A 10% increase in public welfare spending would reduce the current Black-white disparity in cancer survival of 10.8% by about 4.6, said Barnes. The association between increased public welfare spending and improved overall survival for Black patients was consistent across multiple types of cancer, including solid tumors and hematologic malignancies. The improved survival reduced the Black-white disparity by about 40 to 50% across different types of cancer. Wow. Do you have any thoughts on that? It just goes to show that targeted spending in the right places.
Well, let's not get carried away here.
Spending in the right places leads to tangible and visible results.
I think some good things were done, but I think that we need to get it a little bit, we have to look at it at this more specifically what was done. Not necessarily
that's a good point.
Just social welfare. I mean, that could be anything.
No, yes.
That could be anywhere from billboard ads.
I said targeted spending.
Yeah.
I didn't say just cut a blank check.
So what I think, what the research is showing in other fields is access to care.
Yes.
And awareness that these things have to happen, and preventative care, meaning getting to your doctor not when you've got a stage 3 cancer, but a stage 1 or 2, is extremely important in terms of survival. And because this is now being effectuaed, also, we're going to get into it a little bit later on.
Well, but because of the money, you're not waiting until you're writhing in pain to see the doctor.
But also,
you have the option to see the doctor.
This is not the only
sooner.
thing that's changed. And when a lot of things change at the same time, it's easy to claim victory.
All right, so what do you think has changed?
I think the fact that we now have the Affordable Care Act. I think the ACA.
There's still a number of states that have not embraced it.
Numbers of states that have not, but there's enough states that have gone the ACA route that, it's given that group of people healthcare or access to healthcare where they didn't have it before. And if we say, okay, we realize that the numbers are getting better, but is it because of ACA? Is it because of spending in the social welfare programs? Where is it?
Yeah,
it's
they don't
coming
really
from.
say where the money is. It because people are buying better food? Is it because they can get to the doctor sooner? Yeah, they don't really specify. They just it's kind
And
of
you know
a
what? They don't
blanket.
really know. They just know that if you do these 7 things, things get better. But which of the things that you're doing is the thing that's really causing the change? And I'm all for it. If we have to keep doing the 7 things just to keep the people alive, that's fine. But if there's one in particular that's really working, maybe we could do more of that. Or maybe we could shift the money there.
It would be good to see what they found was working, what in particular they found was working, because just to simply say, hey, let's just flood the market with this money, which I don't think that's what they're saying,
They're
but
not
it's
saying
sort of
that, but you know how cheap
it's
I am, so
it
I go
it
crazy.
yes, it sort of reads that way, like just because they're saying wealthier, they're not necessarily saying money
Well,
towards
they
health.
use that word welfare, which is a political trigger word. I wish they would have called it something else, and I wish they would have been a little bit
My
more specific in the
God,
article.
why are
But
you calling it a trigger word?
I think it is. I think
A trigger how?
I think a lot of people look at it and just have negative connotations towards the term. I think that I think that they could call it a different thing. I mean, it's still programs out there that are helping the underserved, that are creating health awareness and are creating access to healthcare and access to other healthier environments. But what are those programs? That's what I'd like to know, is exactly how that money was spent.
I agree with you there. I would like to see exactly where the money went to make the difference. I think this shows that a difference can be made somewhere, somehow. And I'd like, for the government or at least the state governments to take a closer look at this data
Mhm,
and drill down and figure out
mhm,
where this money has spent, where in particular it made this difference, and
mhm,
then emulate that because this clearly somehow is working. So, but we
mhm.
just need to fine tune it,
Right.
right? So it needs to be, better honed
Yep.
so that the money is spent carefully and it's spent strategically.
Mhm,
Value-based care versus fee-for-service care. So now we're going to jump into the topic du jour
mhm,
because, like I said, we have an interview coming up.
mhm,
The healthcare revolution is already here. It's not the debate around Medicare for all, nor the question of whether to repeat or expand the Affordable Care Act. It's the continued shift from fee-for-service models to a system of value-based care. And while it's largely taking place behind the scenes, it's having enormous impacts on healthcare providers. The transition to value-based care revolves around a recalibration of how healthcare is measured and how payments are reimbursed. The traditional model, known as fee-for-service, simply assigns reimbursements based on what services a healthcare organization provides. But in value-based service, reimbursement is contingent upon the quality of the care provided, and it comes tethered to patient outcomes. This seemingly simple pivot of emphasis actually requires major changes on the part of healthcare providers. The old fee-for-service model encourages healthcare providers to fill as many beds and perform as many high-tech procedures as possible. That succeeds in driving up the cost of healthcare, but it doesn't improve patient outcomes. Value-based care, on the other hand, puts the quality of outcomes first, and by tethering reimbursements to this metric, incentivizes healthcare providers to prioritize patients. Both Medicare and private insurers have begun to adopt value-based models, and providers, along with a fleet of healthcare administrators, have had to rethink how they can conform to the new system while meeting budgetary limitations. I definitely see this as the future of medicine.
Well,
Insurers want to rein in costs as healthcare grows out of control with the latest drug or treatment or therapy.
all right. Well, couple of things. 3 things. Three
Okay.
things that I want to point
Okay.
out. And they may take a while, but I'll start off with the first one. If we all look out across the ocean, there's a tsunami coming, people. And that tsunami is not water. That tsunami is called the Grey Tsunami. Now, what is the Grey Tsunami? It's
Baby
the baby
boomers
boomers,
coming
yes. The
of
baby
age.
boomers coming and the baby boomers all going into Medicaid,
Where did you hear
Medicare,
that term, the Grey
all of that.
Tsunami?
It's a new term that's coming out. Now that I'm getting more and more gray, I want to be part of that tsunami. But so it's called the Grey Tsunami.
I like it.
It's a term that's just been coined rather recently,
Mhm.
and that is, just is indicative of the number of people that are moving off of, their regular, I got a job to, okay, now I'm retired, I go on a different healthcare system. That number is 18% a year. So every year, 18% of the people are moving. Forget about the people that are coming on the workforce. This is just people that are getting off the workforce into that, and 18%,
Into retirement and
yeah,
into needing
and are
care.
moving in. So the Medicares of the world and the managed care systems are going up by 18% a year. Now, the only way that ACA can work, the Affordable Care Act can work,
Mhm.
and the only way that Medicaid and Medicare can stay solvent is if they go on a value-based system. They pretty much drive you there, and you don't know it as a patient, but your providers are being incentivized under those formulas. Now, where are the problems? It sounds great. It's already happening. You don't have to do anything.
It does
It's
sound
gonna
great.
seamlessly. It's going to happen. The doctors are going to become commissioned employees.
Well, nobody said that it's going to happen seamlessly. It is going to happen over time, though, and it's currently like in the works. And look, if the
Yeah.
benefit means more people will be healthier, then it's
Mhm.
time that this bubbles out into the medical school curriculum, so doctors
Well,
are learning not just how to treat sickness, because that's what they do. They treat sickness,
it's not as much as
but how to
curriculum.
prevent it.
Okay, my feeling is it's a psychology, because many doctors are independent business men and women.
Not if you
Eh,
work in a hospital system.
Well, more and more. They used to be termed like hospitalist, and physicians used to look at themselves as hospital-based versus, office-based. That those lines are really, really starting to diminish. Most physicians are now affiliated one way or another
With a hospital.
with some sort of care system, whether it's a
Mhm.
hospital or an urgent care system or something like that. There's an affiliation there. The independent physician is very, very rare right now. It's very difficult to stay
Yes,
that way.
yes, that's true.
And this goes into other implications, like how they're going to pay their student loans and what kind of practice they're going to have, and blah blah blah. But I'm not even going to get into that. In order for value-based medicine to work, it needs an information system. We call it an AI, an informatics system. Let's call it AI for now, because everybody's familiar
Yeah,
with
let's
that
call
term.
it AI. Mhm.
It needs AI that helps the physician manage it, keep track of things, and see where deficiencies are, and to actually use your AI to talk to the provider's AI on the other side, just so you could use
Now, who's your AI that you're
your
talking about?
AI is the doctor. I'm a doctor. I
Okay.
got all these patients, and all these
Or
patients
an
are doing all
NP
this,
or a PA.
or a PA, or and whatever.
Mhm.
I got to get everybody's information, put it into what's called metadata, meaning get everybody's numbers and put everybody's data together, submit that to the insurer for reimbursement, because I'm not getting reimbursed anymore for Sally Jones coming into my office. I'm being reimbursed for watching over 600 patients, what the outcomes of these patients are, the overall health of these populations, or are they within norms? Now, how do I do all of that if I don't have an AI system? The answer is it's very difficult, and it's led to a lot of incorrect reporting. So, this is a good idea, but we need infrastructure around it, and we need the tools around it. And that's a very important topic that's going to come up more and more and more. Secondly, if we look at right now what's happened so far with value-based medicine versus
Fee for
regular
service.
fee for service or any other type of bartering, I'll give you my horse if you take care of me type of medicine, is that
not so much. That doesn't that
that
doesn't
doesn't go
exist.
on anymore?
No, that doesn't
Oh, I
exist
used to
anymore.
do that back in the
Used
day.
to be,
I'll give
bring
you,
the doctor
I'll bring you some
a
corn
peach
or
cobbler or
some
a baked
fish.
apple pie.
Yeah,
or
bake
some-
it.
yeah.
Give you a baked
No,
pie. And
now they want,
it's done.
now they want
Jesus.
greenbacks.
God, I'm dated myself. But what the evidence is showing right now is there's been no significant difference, and that's one of the I'm not going to.
But the lack of
ACA.
significant difference is because of how doctors are trained. They are trained
Exactly.
to look for and treat a condition, to treat a symptom.
Right.
You got pain, let me prescribe something for you. But anyway, I had a great conversation with Bruce Crowther, former hospital executive and board member for Gray Matter Analytics, about this topic. So let's take a listen. Hi, I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Bruce Crowther, who serves as president and CEO of Northwest Community Healthcare, Northwest Community Hospital, and affiliates in the greater Chicago area for more than 20 years. He's also a fellow of the American College of Healthcare Executives and past board chairman of the Illinois Hospital Association. Currently sits on numerous boards and remains involved in healthcare data and analytics consulting as it relates to health equity. He's here to talk about value-based care and how it can help mitigate health inequity in hospital systems. So thanks for talking with me today, Mr. Crowther.
It's a delight, Tamara. Glad to be here.
Great, so let's get started. In your experience, what do you see or think is driving health inequities in healthcare? And why haven't they come to light before the pandemic?
Well, it's a few things, but first we should let's establish that there really are inequities in the delivery of healthcare. And if you asked any doctor or nurse, they see it. They wish it weren't there, but everybody knows that people of color, particularly, fare worse than their white counterparts for health measures across the spectrum: infant mortality, pregnancy-related deaths, the prevalence of chronic conditions, and just overall physical and mental health status. So it's there. I think COVID really brought it to light. But the drivers of this, I think, are a few. One, at a very broad level, healthcare in this country, and it's one of the few fully developed countries like this, but healthcare is a right, or is not a right, it's a privilege, which means you have to be able to afford it. And of course, there are special provisions that have been made. Medicare is a big part of healthcare now, Medicaid, and special Social Security programs. But at the end of the day, it's a privilege, and at some point, we're going to have to declare it a right if we're going to solve these inequities. The other, a couple of other, I think, root causes. One is only 50% of Americans, and I haven't seen this, and I wish someone would do the study. I haven't seen it by race or income status, but only 50% of Americans have a primary care doctor, which causes a really serious misuse of the way healthcare is accessed. And then the final is that we've historically been a fee-for-service cost-based system that's very, very expensive. And for 30 or close to 40 years, we've been trying to get to something called value-based medicine or value-based care. And really just haven't had the information systems to make it work. So that's my thinking on what's driving these things.
Can you just expand a little more? I'm just blown away by this information here, that the insurance, that healthcare is not a right, but a privilege, and that only 50% of Americans have a primary care doctor. Is that because of the lack of availability? Like there are some areas, for example, that are health deserts. Is that the cause, or is it because people just don't have the money for care? Is it lack of availability of providers, or is it lack of funds on the part of patients?
You know,
If that's
I think,
something.
yeah, and I think it's probably a little bit of both. But a health desert occurs when there aren't enough people there to financially support a facility or the creation of health services. And I know there are programs that are for free clinics and subsidized kinds of things, but at the end of the day, somebody is always paying that bill, and there's never enough money for it. And that's, I think, how we get to specific locations that just don't have healthcare.
Huh. Okay, well, aside from the pandemic, what else has helped to bring these inequities to light?
Boy, I think, let me just speak a little bit about the pandemic, because I think it really did highlight, it just made this so obvious. And I think the reason it could make it obvious is that the Centers for Disease Control and Prevention were kind of in charge. They were making the rules, which allowed them to collect the data on every patient. And so it's a very broad database. And just to give you an example, what it showed was Black Americans were close, a little more than 10% more likely than white people in the United States to contract COVID, but 240% more likely to be hospitalized and 70% more likely to die from it. The Hispanic population, 50% more likely than white Americans to contract it, 230% more likely to be admitted to a hospital, and 80% more likely to die. That is, real disparity. And it's the first time, the reason it was highlighted was we had the data. And you probably know that one of the boards that I work with is Gray Matter Analytics. And for probably close to 40 years, I have watched attempts in the industry to create databases that would highlight these kinds of problems and then track them over time to give feedback on what's working, what's improving, what's not improving the situation. And Gray Matter is the first company that I've ever seen that's actually being successful at being able to create the tool, if you will, that can drive changes in these kinds of situations, both at a macro or a demographic level, but also at a micro level, because there are reasons, I think, that some of these things happen. And as you pointed out, one is access, one is the payment system. And I know in a few minutes you'd like to talk about value-based care, and I think we should, because that's a significant change in the payment system that only happens when you've got the measurement tool to let you know what's working and what's not working, and to identify the problems as they occur.
But let's stay with this for a second, because a lot of what was said in the media about the reasons for the high hospitalizations of Black Americans and Hispanic Americans was because they're in jobs that put them in the front lines. I mean, is that what you're seeing? Because it sounds like if they're getting the rates kind of very similar to their white counterparts, then their outcomes, one would think, should be similar, but that's not what's happening. So there's more to the story than just the jobs they do, correct?
Yeah, there's got to be. I think the jobs are part of it, but I think that's a really broad generalization to say that Blacks and Hispanics are that much more in, let's call them the high exposure jobs. I think there is an element of that.
I agree.
Yeah, but think too, and I don't know the data on this and would love to see it. What is the percentage of people of color that have a primary care doctor? Because if you don't have a primary, and I don't know it, but if you have one and you get symptoms, you call your primary care doctor, and your doctor assesses the situation and advises you on what to do next. And that could be stay home, or it could be you better get to the emergency room. If you don't have a primary care doctor, then you don't have that resource to call, and you wait as long as you can, and then now you can't breathe. You've really waited too long in most cases, I think. So you're headed possibly by ambulance, but you're headed to the emergency room, and that patient is getting there. You know, when we look at the data, that person is getting there much later in terms of the development of this disease,
Right.
without treatment, than the person that didn't have a primary care doctor. And I really think that's a critical part of the equation that I've not seen any data on. So part of it has to do with what are the activities that you must do that might expose you more. And I think we've had a lot of press about that. But the other has to do with what are the resources available to you early on in this disease to handle it as efficiently and as quickly as possible.
So let's talk about value-based care. What is it, and how do hospitals and medical professionals use it?
It's so value-based care is an alternative to what we've had in the past, which is fee-for-service. And so in the past, you know, it's like anything else. You go to a doctor, they send you a bill. You get, you know, a test, they send you a bill, and so on. So it's based on consumption, and it's really built around fixing. It's a repair shop model, okay? But there's minimal emphasis and minimal payment, in fact, for doctors. There's involved in prevention. Value-based care is about keeping you healthy, and when you're not healthy, being able to identify the most effective way of getting you treated and well. And its predecessor, you remember HMOs, or health maintenance organizations, they were, I think, started right back in the 80s, and they've had a lot of starts and stops. And the idea, but it's a similar idea. The idea was you, instead of paying by an incident as an insurance company, as an HMO insurance company, I'm going to accept your payment as a premium, as a patient. You're going to be assigned to a doctor, and that doctor now has been paid. They don't get any more, any less. They've been prepaid more or less. And that creates an incentive on the part of the doctor to see you more often, do more wellness checks, and to both keep you healthy, and if they see some signs of something about to occur, identify it early enough that it can be inexpensively taken care of, rather than waiting until it's a full-blown medical issue that requires a hospitalization. Clearly, the most expensive place to go in the health system is the hospital. And within the hospital, it's the ICU and in the operating rooms, and you know. But the idea was to be able to keep you out of the hospital and keep you in focus on wellness. The problem, and I think the reason that has largely not done its job, is that we didn't have the data management systems to really, for the doctor to really understand, to monitor you and understand what's working what's not, both for you as a patient, but in the broader patient population that you're in charge of. And they really couldn't get a metric for, okay, am I improving the health of this population, or am I just trying to be cheap? And so that has evolved into something called value-based medicine. And value-based medicine has the same basic intent, but we're doing it at a time where the data systems are improved. We have this thing called artificial intelligence, which allows, as you set up your data management systems and your databases, computers can actually collect data and see trends over time that don't require human intervention, so to speak, and can identify, here's what's going on with your population. And I have seen this tried and tried so many times in my 40 years of working in the healthcare industry. And I have to say that what Gray Matter is doing is the first time I've seen it being done in a way that's easily managed at the hospital or insurance company level. And it really works. It's really providing value. And so value-based medicine is really something, it's a payment system and a patient management system that whose intent is to keep patients well, identify diseases early, but also identify for different populations of patients, what works the best in this for my patient. So if I get, I don't know, I've had a couple of bouts with cancer, and boy, 20 years ago, we treated every cancer patient the same, and now we use the genetic makeup of the patient to customize treatment, and the treatments are so much more effective. Value-based medicine has the intent to basically be able to do that, to identify it, and to make you healthier as a patient, make a population of people healthier, and do it at a lower cost.
It just seems counter to the way doctors are trained, though, doesn't it? Because they're trained to treat illness and disease. They're not really trained to prevent illness and disease. So,
boy, yeah, Tamara, that is a great insight. We're now you start to see the enormity of this shift. Yeah, you're exactly right. Doctors are trained to fix things and to treat disease. And interestingly, they are, so the education system will have to change. And I'll give you a couple of examples. Under fee for service, the demand for services like surgeons, procedure-based kinds of things is very high. So in medical school, everybody's going into a specialty. I say everybody. Probably too many people are going into specialties. I want to be a heart surgeon, a general surgeon, a brain surgeon. I want to be a radiologist. And few people were going into, or not enough, primary care medicine. And
absolutely
because
right.
because over time, that's where you make the money, doing these procedures, not seeing a patient in the office. And I realize that, I said that 50% of people in the country don't have a primary care doctor. I also anticipate and have for some time that there is going to be, as we shift into value-based medicine, a shortage of primary care doctors and too many specialists. So if everybody decided I need a primary care doctor, I don't think there'll be enough of them right now to meet that demand. Now, having said that, the medical education system can change. One of the things that was being taught for many, many years to physicians was certainly, you know, the phrase "do no harm," but also we were teaching doctors to continue to treat, and that was very often we'd do procedures on patients that were too old or too sick to handle the procedures, and the recovery from the procedure, even though it was an attempt to save them, was harder on them than, and they still passed away.
Right.
Was harder on them than you know, not treating them at all or just treating the symptoms, and which they have been doing for years in Canada and Europe. So there was a specialty of medicine introduced probably 20 years ago in this country, but it's really quite prevalent now, called palliative care, where there's a point where someone needs to make the call that, you know, you're going to live longer and more comfortably if we stop trying to cure you and manage your symptoms so that you can be comfortable for the rest of your life. And so there are doctors coming out now, and most hospitals have them, where when that determination is made and there's a discussion with the family and so on, then you fall into the care of a palliation specialist. And those specialists didn't exist, I'm going to say 20 years ago. So the industry and the education system for physicians is capable of changing, and I'm quite sure that with the development of the emphasis on value-based medicine and the development of the kinds of systems and data management and artificial intelligence capabilities that companies like Gray Matter Analytics have, I'm quite confident that that's going to drive the change in the medical system. But we are clearly going to have to change that medical system to accommodate this.
If I could just piggyback on something else, you were talking about the lack of primary care physicians. The other thing, there was a big article in the New York Times, and I personally am a big believer in graduating more physicians of color, particularly into the PCP space. And what's happening is a lot of the doctors that are graduating can't afford to go into primary care because they're laden with so much debt from medical school that they just can't afford. They have to go into a specialty to be able to pay off. So they can't go back to the community and help like they'd like to. So that's another issue in terms of the shortage on primary care doctors. Yeah, so I just wanted to throw that in there. Now, how can the use of AI and value-based care help reduce inequities in medicine?
Well, the use of artificial intelligence is going to give us the data we need to get to value-based medicine. But it's, boy, you just raised a really interesting sort of the chicken, which just comes first, the chicken or the egg. I'd love to see the medical education industry reforming itself so that you can make a living, you can pay off your debt with as a primary care physician. We're going to have to create some kind of financial system or incentive to solve that. Artificial intelligence and these kinds of computer or guidance systems is going to accelerate the movement away from fee-for-service and toward value-based medicine. The quarterback in fee-for-service seems to have become the specialist, or some would argue it. The quarterback is the primary care doctor who just decides which specialist to send the patient to. But you know, the quarterback, in my view, has been the specialist. Under value-based medicine, using our artificial intelligence to monitor the patient's health, to monitor the either the improvement or the decline in health of populations is going to be done by the primary care doctor. And I just really hope that we can figure out a way to make that worth their while, because it's going to be, they need to be paid. There needs to be a financial incentive given the cost of medical school. I mentioned earlier that healthcare is not a privilege yet in this country; it's a right, and that means that in part the education system is also a privilege. You got to be able to afford it, and if it were to be, and by the way, I spent a whole career arguing the other side, arguing that healthcare should be privately managed, and I just am frustrated and don't see it working. So if we were to make it a publicly funded right, my guess is that we would also do something to manage the or give the medical schools a financial incentive to graduate the right mix of doctors, if you will, so that we did have more primary care doctors coming out and fewer specialists. That's another thing that artificial intelligence and these kinds of systems can help predict. These are basically predictive models, and over time they become very accurate, and they can tell us, in 10 years, this is the mix of doctors that we need, not what we have today. And directionally, I can say it's going to be a lot more primary care doctors and a lot fewer, orthopedic surgeons and so on. So, specialists.
And that's kind of the other problem, though, from where I sit, is that most people, most low-income people, most people, including low-income people, their first touch point is the primary care. They don't even get to the specialist, right? Most of the time, they don't even get to the specialist because they can't afford the specialist. So I'm curious how we overcome that.
I see it a little differently, and I think the first touch point for everybody should be the primary care doctor. Rather than
yes,
so everybody should have that. Now, when the primary care doctor says, you need surgery or you need to see a specialist, and you feel that you can't afford it. If you can't afford it, it means you don't have access to an insurance program, at least under the fee-for-service. Actually, it's going to be that case under value-based medicine. I'm just hoping that value-based medicine, that we've evolved to a point where everybody, this is where I get the difference between a right and a privilege. Everybody needs to have that coverage. There should never be a situation where I need a medical procedure and I can't afford it. I can't get access to it. It's really interesting. Most hospitals in the country are not for profit, and in exchange for, which means they don't pay taxes, and in exchange for that, they have a responsibility to take care of the people that need something and don't have the means or the money to have that procedure. I do think that that's and the idea was the money you would have paid in taxes is now not going to the government. It's going to cover the care that you're going to provide to people that don't have the means.
Right.
And that works in certain communities where there are very few people. But if you, as you know, there are people without insurance and without means all over, but there are also concentrations of them, especially in urban areas.
Right.
And so if you're the hospital in that area, you can't you can't cover the needs of everybody if you don't have anybody paying the bill, if you know what I mean.
Right.
And that's the situation we find ourselves in. And that's why I really believe that we need to find a way to make this a right where everybody has access, everybody has coverage. Otherwise, we're going to continue having these inequities.
So can you walk me through exactly how, so I'm a patient, I go to see the doctor, and this doctor is using AI and value-based care. And I come in, my A1C is a little high, I'm pre-diabetic. How does this then kick in?
Well, in a few ways. One, that's great that you went to your doctor and you're pre-diabetic. So he or she is going to put you on a preventive plan. They might send you to a diabetes physician. They may change your diet, they may change your exercise routine, but they're going to do their best to keep this from progressing. And the systems that they have in place are capable of saying, okay, for someone with, at this stage of being pre-diabetic, these are and they're going to, they'll input other characteristics that you have. I know you're not, but you could be obese or overweight. You could not have access to healthy food. It could be a lot of things. And these kinds of systems over time will tell you, okay, these are the things you need to know and care about. So the artificial intelligence can not only help at the physician level, but again, at the population level. And it'll be a reference point. Physicians have access to, they're smart people. They've been trained to handle pre-diabetic people. And so they probably don't need this as much to give you a diagnosis and a treatment plan. Over time, though, you're going to be in their database and they're going to have a better sense of what's working, what's not working, what do you respond best to, what don't you respond best to. And, it will become an integral part of care. I should say most doctors have many doctors have a computer system that does not include artificial intelligence, AI, and they do very well on a patient-by-patient basis. But when you start managing populations, that's where you have the opportunity to see that, okay, I'm in a group of physicians, and if we look at how each of us is treating our pre-diabetic patients, each of them will be slightly different. The primary care doctor one guy may be, he's managing it himself. Another guy has already sent you to a diabetes specialist, and they're going to be able to compare the outcomes and identify that, this woman physician over here is doing it differently than all of us, and she's getting consistently better results. And so as a group, let's migrate to what she's doing. That's really where these kinds of systems become really helpful at a physician level. They're identifying best practices for you and making you aware of them as they collect data on all of your patients over time.
So this is something that physicians have to sort of buy into, right? They have to request this. Is that how it works?
Well, or they have to agree to be, to use it.
Or qualify.
But,
okay.
Yeah. So the big adjustment in this arena for physicians, I think, occurred quite a few years ago when they needed to start using computers. And it's just because we had a generation of doctors that didn't have computers when they started, and now you're making me change.
Mhm.
So we've moved past that. You know, the people coming out of medical school now are all really savvy about computers. And this, I think, is looked at as a very sophisticated tool. I can't imagine that they wouldn't want artificial intelligence, but that's kind of at a physician preference level. When you shift to taking contracts, you know, physicians have been, you don't see many solo physicians anymore. You see groups,
Right.
and groups sign contracts with insurance companies and with Medicare and with Medicaid. And increasingly, those insurers are moving away from fee for service and moving to a value-based
Ah,
kind
so this is led by the insurance.
of
Okay.
system.
Okay.
Yeah. So now, okay, now you've written a contract, and you're going to be paid on some metrics around the health of this population. So you really want this artificial intelligence kind of system. You have an incentive to use it, so that you're able to interpret best practices. You're able to see how your cost profile versus outcome is working relative to others, and you're going to maximize your income, your payments that way. So that's really, I don't think this is a tough conversion. They're already, I'm going to say, taking value-based contracts, but everybody's still trying to figure out how they work, because the system, everybody doesn't have the system available to them yet, and or a system like this that works. They have some subset that is, you know, clumsy, new, hard to use, that kind of thing. But artificial intelligence is really developing at a fast rate, and yeah, I think if you give it 10 years, this is going to be a very popular way to go. Keeping in mind, and I'll use the gray matter analytic experience.
Mhm.
They're selling this not only to doctors and hospitals, but they're also selling it to the insurance companies. So if I'm writing a contract, I'm a physician group, let's say, with an insurance company that has this, I don't want them having all the data and interpreting it and basing their payment to me on it without my having it and being able to manage my my practice with it. I also don't want to, and this has happened for years, I don't want to agree to a certain payment without having the data to support that I can manage this population of patients with that amount of money. And so they've been kind of contracting blindly for a number of years, and this movement is I think making them a little better informed when they negotiate with insurance companies and write contracts.
So do you think that many organizations will fully embrace this model of care given the challenges we've just discussed? Or do you think
Yeah,
that-
I do. I really do. The challenges we're talking about are transitional challenges. Yeah, but if at the base of it is a change in the way that healthcare is paid, and you know, everybody will eventually get in line and follow the money, and that seems to be the way of it in this country. So if we're switching from fee for service over time to value-based medicine, and there are the tools available, which they were not when this movement started 30 or 40 years ago, but they are available now to know what you need to know to manage under a value-based system. Then yeah, I think this is catching on, and it's going to be the way medicine is paid for going forward. But all of these transitions, you know, they do take time. So this isn't something that's going to happen just overnight. It's going to happen. You know, it's a decade kind of thing. And you know, keep in mind that. So for physicians that are in the field right now, even though they have computer systems, they probably don't have artificial intelligence yet. But as artificial intelligence kinds of capabilities are developed, the medical schools will be teaching, this is how you manage when you have this tool available to you. So in order to completely make the transition, you've got to have a generation of doctors that come out that have been trained on these kinds of tools and incorporating it into their understanding of how the practice of medicine should work.
And also on preventive medicine.
Well, that's a huge part of this. Yeah, this is really, at its base, a return to prioritizing preventive medicine as, more important than cure. And I can't say more important, but somewhere along the line, preventive medicine was lost as a priority, and I'm pretty sure it's because you couldn't make much money doing it. I remember when I was running Northwest Community Hospital, we used to try to set up free clinics and this was in the HMO days, because it was, we knew that there were patients that we were going to take care of one way or the other. They didn't have access to insurance, and it was cheaper to give them free clinic care and prevent them from getting sick than it was to have them show up in the ICU, show up in the emergency room, go to the ICU, and cover the cost of that experience. So, there was a financial model that would support even free preventive care, but we also knew that the insurers didn't really pay for it. Even for the insured people, it was, it's a low margin kind of or part of the business of delivering healthcare. So I think this will put that back front and center where it should be, and realign, I guess, the financial system with the incentives, which in turn will probably, I hope, create more primary care doctors that are able to practice preventive medicine rather than everything being a repair.
So if this is a 10-year strategy, a 10-year plan, do you think that there's anything else that will happen in the near future to help mitigate inequity, or are we sitting on 10 years before we see those changes in healthcare?
Well, when I say 10 years, I think this is changing.
In terms of it's got to turn over, it's got to get into the medical schools, the AMA has to embrace it, make it part of the curriculum. These new doctors have to embrace it, and the thinking has to change. So I get that. So I understand it's going to take about that time. But inequity is a problem today. And so I'm wondering if there's anything else that we could do to, I guess, get there faster. And if there isn't,
Yeah. Tim, I think the most important thing to realize is that value-based medicine contracts are being written today, and they're replacing fee-for-service contracts today. So the incentives that are required to make this change are already happening, which means the changes are already happening. So, whether we have over 10 years, there's no data to support this, but just as a mental model or a directional model, I don't see we going from 0 to 100% in 10 years. It's 10% each year, or maybe it's 5% this year and 15% next year, and so maybe it increases at an increasing rate. But I think we're in the movement now, and I think it's going to solve a lot. Keeping in mind, going back to the COVID situation, I hope this system align, starts to improve the kinds of hospitalization and death rates, and COVID's going to be around for a while, I think. I hope that starts to improve as we have the data real time, and as we begin to see that, get to the underlying root causes of, what is it that makes a Black or Hispanic person more likely to be hospitalized for COVID. Clearly it's, there's the kind of work that's done, but there's got to be something else. And my theory is that it's the availability of primary care, so that you have a doctor and a resource to consult early on. But there might be more to that. There might be, I don't know, there could be genetics there. But these AI systems, these artificial intelligence systems, are capable of learning that over time, and starting to narrow the gaps and get us aligned as we should be. The results for everybody should be the same, and I'm really excited about the potential that this has for making those changes. First, recognizing the problems and recognizing them as problems, and then understanding the underlying causes, and so that we can make some changes and effectively make medicine not only the right that it is, but the equal right that it is.
Well said. Well said. Mr. Bruce Crowther, thank you so much for your time today. I really appreciate this education.
It's been a pleasure. Anytime. Thank you.
Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.